Good evening there, everybody. Could I ask that the speakers for tonight might just check in with me there? Just make sure we're on your line.
Hi, Kieran. Ger Curley here.
Hi, Ger. Great to see you again.
Paul O'Neill is here.
Hiya, Paul.
Emmett O'Brien.
Hi, Emmett. That's great. And Neville.
Kieran, can you see me?
No. Emmett, I see you now.
How do I turn this camera, Ger? Hello. Yeah, okay. Kieran, I just have, if you can hear me there, I have Peter Walsh and Fergal Glynn are having difficulty actually accessing.
Paul, your camera's on now.
Oh, great. Can you hear me, Kieran?
Yes, Paul, I hear you. So who is it?
Just Peter Walsh is calling me there, just saying he's having difficulty actually accessing the webinar.
Okay. Peter Walsh and who else?
Fergal Glynn.
Fergal Glynn. Okay. Well, I'll just see if one of the team can just resend, ask them to join in. They'll get an email.
They can try and send you another email, Peter. Is that okay?
Yeah, Kieran, we'll do that.
Thanks, Paula.
Yeah. Yeah, I don't know, but anyway. Okay. 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 There you go. You're perfect.
I'll just close it so there's no.
Yeah.
So just checking it. Neville, have we got you on the line?
Yep, Kieran, can you hear me?
Yes, indeed. How are you?
Good, and you?
Not too bad. Austin, the last time we saw each other, isn't it? One of those stories.
Isn't it? Anyway.
It's a different world now, that's for sure.
It certainly is.
Yeah.
I presume this isn't going out on the webinar, is it?
Of course it is.
Yeah, it is.
Bit of banter, you know.
Okay.
Now, so I think we nearly have everybody on the line. Is the President, Ken, are you on the line?
Yeah, I can hear you. Sorry, I've just turned on the mic. Yeah.
Oh, great. Perfect. Perfect. Well, I think that we have everybody here, and if that's the case, we might as well get started. So if I could ask everybody just to mute their microphones now, that will save any echo, and then I'll introduce the session and we'll get started. Thanks. Okay, so good evening, everybody, and welcome to our third installment of a weekly webinar from RCSI to address the various issues that are going on in surgery in Ireland during the COVID-19 outbreak. Tonight, we're going to focus on otolaryngology, head and neck surgery, and we are going to be joined today by Professor James Paul O'Neill, who's going to talk about tracheostomy insertion in ventilated COVID-19 patients. And then we're going to hear from Professor Ger Curley again on ARDS management. And then move on to Mr. Neville Shine, who will talk to us about open tracheostomy insertion. And finally, then we're joined by Dr. Emmett O'Brien, who's a consultant respiratory physician, and talk about the post-op kind of ward level tracheostomy management. Emmett kindly stepped in there because Ross Morgan was just unavailable due to clinical duties. So we're delighted with that lineup. It's going to be very, very interesting to hear that, and I think it's really timely as we start really contemplating how we start working on activating surgical services in our hospitals, and managing the airway is going to be very, very important. So as we do with all our webinars, we're going to have the President say a few words and open up and give us a sort of a state of the nation, if you want, on where things are at. And then we can get down to the speakers. So I'll ask our President, Mr. Ken Mealy, to open up. Thank you.
Kieran, thanks very much, and you're all very welcome. I hope all of you, your colleagues and your trainees and your families are remaining well during this difficult period. I would like at the onset to acknowledge Kieran and Surgical Affairs, because despite what many may think, a lot is actually still happening behind the scenes. At a college level, we interact with the senior leaders meeting, which is run by the Department of Health every week. So we get a very high-end update on developments in terms of dealing with the COVID pandemic. We're also involved with the COVID-19 forum, which is run by the Chief Clinical Officer, Colin Henry, and the HSE, and again, deal with various issues such as PPE, for instance, how we protect our staff, and I'll come back to that in a moment. We also have a lot of engagement with the Forum of Postgraduate Training Bodies, which is chaired by Justin Brophy, because training clearly is important, and we understand that many of our trainees have concerns about what is going to happen to them in the coming months, and particularly for the craft specialties such as surgery, there clearly will be challenges ahead. And also we interact very closely with our intercollegiate partners, the colleges in London, Edinburgh and Glasgow, and a lot of the documentation we have used in terms of guidelines and best practice is released at an intercollegiate level, because we feel this strengthens the robustness of the research behind it and the opinions expressed therein. I'm also very aware that this is confusing in terms of guidelines, because the guidelines are repeatedly being updated. So, for instance, we had major issues in terms of use of PPE for aerosol generating procedures. And one of the reasons for tonight's webinar and looking at aerosol generated procedures in terms of the upper airway with anesthesiology, otolaryngology, head and neck and respiratory physician input is because we know from experience in other countries that procedures around these specialties are clearly high risk for COVID positive patients. I'm pleased to say that following ongoing discussions with the other professional bodies and the Chief Clinical Officer, we do now have agreement from the Health Protection Surveillance Centre that the most up-to-date PPE guidelines issued on the 9th of April take into account that all aerosol generating procedures, any doctors involved in these procedures should use full PPE. And this is really very important in terms of protecting ourselves, our teams, but also other teams that are involved with us, whether it be in recovery bay, in the anaesthetic room, or in the operating theatre. Another area that I want to touch on is in relation to a commitment we've given to the Chief Medical Officer that we will support guidelines in which we don't need PPE, because you're probably all aware that there are huge constraints in terms of acquiring appropriate PPE for all healthcare workers. And there is a particular issue with full-length gowns, for instance, that are completely water repellent. And over the coming days, this will be an issue. So we have indicated that we fully support the fact that it is only for aerosol generating procedures that doctors need to be fully gowned up with full PPE. For no non-COVID pathways within hospitals, standard precautions are quite adequate. Another area I wish to just address briefly today is correspondence we've had from the Medical Council highlighting the importance of continuity of care for our patients. And I think we all understand that for both the surgical communities working in both the public and the private sector, this poses difficult challenges. And the correspondence stresses the importance that all of us should do everything to the utmost of our power to maintain continuity of care for those patients that we deem to be at risk for failure to implement treatment. And in that regard, we would hope in the coming week to be able to publish guidelines in conjunction with the Department of Health, the HSE, and other interested bodies as to how we will manage time-dependent and urgent surgical care for patients that fit into that category. Clearly, there's been a huge unmet need over the last number of weeks as routine care as such has disappeared from our acute hospitals. Now that the private hospitals have been taken on board by the HSE, however, we would hope to see more structured pathways and care pathways developed for patients that may be suitable for treatment in the private sector. But clearly, this is complex, and the logistics of management and quality assurance, data management, and so forth needs to be worked out. As always, we would welcome your feedback for individuals to contact either myself or Surgical Affairs, Kieran, or any members of his team. It is important that we attempt, at the very least, to address the concerns of our members and fellows around the country. And with that in mind, the next couple of meetings, webinars that we have organised will deal with cancer surgery. And I know NCCP have issued guidelines, and we've had some input into those guidelines in terms of management of cancer patients during the COVID period. We also will spend some time in the coming weeks looking at how we might manage recovery from the COVID period. It is becoming increasingly apparent to many of us that this COVID pandemic is not going to be over in the next month or thereabouts. This may take a lot longer to resolve, and some of the modelling that we hear about in the Senior Leaders Forum with the Department of Health indicates that well into the autumn there may still be a significant number of COVID patients presenting on a daily basis, and clearly this has implications for the routine scheduled surgical services that we try to provide. So the strategies that we're hopefully going to propose in the coming weeks will help deal with for this prolonged period where we believe it may take longer than initially all of us thought in getting back to normal. So we would welcome your feedback, We would like to hear stories from those who have found solutions to problems on a regional basis that we can share with the rest of the country. If there are particular topics that you would like to hear about in terms of in-depth discussion, please let us know, because we'd like to accommodate those. And as I've indicated, as Kieran has indicated, because airway management is so important, that's the topic for tonight. So I look forward to all the speakers and their contributions tonight. Back to you, Kieran. Thank you very much.
President, thank you very, very much for that. And that's an awful lot of interesting information and news. And we will address many of those things in the coming webinars, and information will be going out to everybody. I should also point out that all of the guidelines, as they come in and they get updated and developed, and it is a very much a moving feast at the moment. We put those up on our college website, and they're accessible there to all. It's freely available. There's no logins required. But if you just come onto the college website, click on the COVID-19 information updates, and then you can find the relevant information under the surgical practice box. And all the information is in there. Indeed, the specialty of otolaryngology has been very, very active in this area, and have produced a lot of very useful guidelines here that will be referred to tonight. I can also remind everybody who's participating that we use the chat function on Microsoft Teams to send in any questions or queries that you might have, and that we can put to the panel at the end of the session. And also I'd like to thank everybody who sent in a few questions in advance of the session, which I'll put to the panel later on when the presentations are over. So without any further ado, we're going to move on to the presentations. And first up is Professor James Paul O'Neill, who's a professor of otolaryngology, head and neck surgery in Beaumont Hospital. And Paul will be talking to us about the tracheostomy insertion in ventilated COVID-19 patients. So Paul, if you're ready to go, if you open up your camera and your microphone, and I ask everybody else then to mute their microphones, we can commence. And if you just say next slide, Paul, Paula, who's in the background producing all of this, will move through the slides for you. Thanks. So it looks like we're having a bit of a challenge there getting hold of Paul.
There you are. Kieran, can you hear me now?
Oh, have you now there? How are you? Great.
Great stuff. So thank you very much, both Kieran and Ken. Thank you for organising this evening and for the invitation to be part of it. And good evening, ladies and gentlemen. So if we could go to the next slide, please. So airway management is an essential topic of discussion in these critically ill patients with coronavirus disease. We acknowledge that the recommendations we're going to discuss here, that these may require individualization based on region, facility, resources, clinical expertise, and patient-specific factors. COVID-19 is characterized by a rapid respiratory decompensation and a subsequent need for endotracheal intubation and mechanical ventilation in severe cases. Approximately 5 to 10% of hospitalized patients require invasive mechanical ventilation, the majority of whom fulfill criteria for acute respiratory distress syndrome. Now, from our limited data from China and Italy and our own initial experience here in Ireland, this disease course describes a prolonged intubation and ventilatory support that many of these patients require as they recover from pneumonia, often 15 to 20 days of mechanical ventilation, with several days spent receiving neuromuscular blocking agents and ventilation in the prone patient, and then typically a slow wean from mechanical ventilation. If we go to the next slide, please. So has tracheostomy a role to play? And of course it does. A rapid rise in endotracheal intubations coupled with prolonged ventilation requirements will lead to an increase in tracheostomy procedures requested in the coming weeks and months. Next slide, please. So let's look at some of the experiences. This is in the New England Journal of Medicine, where 1,099 patients. I have to say I have difficulties with these figures and results. 5% ICU admission, that seems reasonable only 2.3% mechanical ventilation and 1.4% RIP. They certainly are very good results, but if we could go to the next slide, please. This was published yesterday from NYU in New York, and we seem to see a different picture, dare I say a more realistic picture. Remember, in an ARDS setting, we would expect a mortality rate anywhere between 35 up to 45%. But in this review to date from NYU, they've had 4,000 patients, 48% were hospitalized. Of their inpatient mortality rate, it was 18.5%. And of their 445 patients who have required mechanical ventilation to date, 36.4% have died. They have shown that age and comorbidities are powerful predictors of hospitalization. However, admission oxygen impairment and markers of inflammation are the most strongly associated with critical illness. Next slide, please. So when we look at these two papers together, why are they so different? Well, one of the reasons possibly why they're so different is when you look at chronic comorbidity, it's only quoted at 25% of the patients in the Chinese study, whereas in the NYU study, they have 71.9% having at least one chronic comorbidity. But in a more recent paper from Wu et al. From the Chinese Center of Disease Control and Prevention, which was also published in JAMA, they have reviewed 72,000 cases in their country. 5% of these patients were critically unwell, and they are reporting in this study a 49% mortality amongst that critically unwell group of patients. So it seems more realistic figures. Next slide, please. So let's go to tracheostomy then, and what are the advantages? The perceived advantages of tracheostomy over prolonged translaryngeal endotracheal intubation include improved patient comfort, reduced sedative drug use, faster weaning from mechanical ventilation, and a shorter hospitalization. However, these are not all necessarily borne out by high-quality studies from the literature. What we can agree with, next slide please, is that tracheostomy formation is an aerosol generating procedure that increases potential viral exposure to the healthcare team, and reducing the risk of nosocomial outbreak amplification through transmission of COVID to other patients and healthcare staff is clearly of critical importance. Next slide, please. What is clear is that the upper aerodigestive tract, and we have some high quality publications showing this, the upper aerodigestive tract, the nasopharynx and the trachea harbor a high viral load, in particular during the acute stages of the infection. Next slide. Nosocomial infection is a very real thing. If we look at the Chinese results, and possibly it's even higher than what's quoted here, but they're quoting 1,700 bedside clinicians infected, and the Italian are quoting 7,763 healthcare workers infected. Next slide, please. So let's see, what do we have when we look to the literature, as always, to guide us? What do we have giving us guidelines in this setting? Because remember, what were guidelines several weeks ago are clearly very different now. We're in a very different disease process, and different reasons why we need to consider a tracheostomy, and also different reasons why we wouldn't necessarily consider a tracheostomy. So with the ENT UK guidelines, overall, I think that it's a nice summary, but they haven't nailed down some critical features or factors. The exact timing of tracheostomy insertion and discussion around that debate, they haven't addressed that. What about the clinical status of the patient? Is there any advice in terms of what the patient should be at, or where the patient should be at? That's not included. In terms of insertion, and Neville Shine will talk more about this, they talk about care not to damage the endotracheal cuff. We'll show you how to make sure that doesn't happen in the open setting, and indeed in a percutaneous setting. They recommend changing the tube at day 7. I would absolutely disagree with that. There is no necessity to change the tube, and they don't discuss timing of decannulation. Next slide, please. If we look at another paper advising us, this is the Italian paper, and again, I would have concerns with this. One of the quotes from the paper is, a recent systematic review revealed how early tracheostomy performed in the first 7 days after orotracheal intubation is associated with a reduction in mechanical ventilation duration, mortality rate, and length of stay. But where are they getting that statement? They're getting it from a paper in 2018, which is a review of timing of tracheostomy in patients with prolonged endotracheal intubation. And this is a review prior to COVID. There's obviously no mention of COVID or anything like that because we didn't have it then. But yet they're basing their recommendations on something pre-COVID days. So I wouldn't agree with this review. And instead, I would look to the next slide, please. A more recent publication from the New York Head and Neck Society. If we go to the next slide, thanks, Kieran. And next slide again, please. What they have recommended is delay in timing of tracheostomy until 21 days post-intubation if feasible. They recommend avoiding a tracheostomy in high mortality risk patients. They say that while data is limited, techniques which avoid opening the airway and are closed, such as a percutaneous dilatational technique, may be preferential in the setting of active infection. And they also recommend that tracheostomy tube changes should be avoided and only performed in cases of cuffed failure or emergent situations. Next slide, please. We wrote this paper about 2 weeks ago and had it published as a special communication in JAMA. And in relation, we looked at all aspects of head and neck surgery, but in relation to tracheostomies, we said that this is ourselves in RCSI and also colleagues in Sloan Kettering, in NYU, in Stanford, etc. In general, most tracheostomy procedures should be avoided or delayed even beyond 14 days because of the high infectious risks of the procedure and subsequent care until such time as the acute phase of infection has passed, when the likelihood of recovery is high, and when the ventilator weaning has become the primary goal of care. Next slide, please. But in all these areas of the literature, these are not multidisciplinary guidelines. They're really more head and neck surgeons or ENT surgeons giving opinions. So what we sought to do was get an agreement or an understanding between ENT, between anesthesia, and between our colleagues in respiratory medicine. And we put together multidisciplinary guidelines. What we found is that we agreed on the vast majority of points. Next slide, please. So just to briefly go through these, and there are other aspects that will be covered in the other talks. Firstly, a multidisciplinary team composing of consultants, surgical anesthetic colleagues, and respiratory physicians should review the cases that are being considered, looking at the risk versus benefit for the patient, the operating clinician, and the healthcare team. So what we're saying here is have that discussion, and have that, if you haven't had that discussion with colleagues in these other departments, it's very important that you have that discussion. Patient selection then is very important. Anatomy, history, comorbidities, and the clinical course of the patient, both current and projected, may result in increased complications and procedures being postponed or indeed cancelled. Next slide, please. In the context of this pandemic, most tracheostomy procedures should be avoided or delayed until after 13 days because of the high risk of viral aerosolization during the acute phase. The anticipated timing for viral clearance cannot be predicted currently. Furthermore, critically ill patients demonstrate longer periods of viral shedding, lasting at least 2 to 3 weeks, and we know that from Zhu et al. In Lancet. The higher the viral load during the acute phase, the higher the aerosolization risk. Next slide, please. Where are we getting this 13 days from? Well, if you look at this, this is a good review from HICWA, where they looked at they questioned what is the viral load over the course of the infection, including any asymptomatic or pre-symptomatic phase, and the duration of infectivity. And 2 areas of conclusion was, first, in general, the highest viral loads were observed at the time of symptom onset and for the first few days after, with levels slowly decreasing over 1 to 3 weeks. At the aggregate study level, the mean duration of viral detection from symptom onset was 13 days. So that's where we got that figure. Next slide, please. Other things that we should, of course, consider is the patient considered for a tracheostomy should be hemodynamically stable with minimal vasopressor requirement. They should not require prone ventilation. They should not require high levels of PEEP. They should not require high fraction of inspired O2 or high pressure support. Avoid tracheostomy in COVID-19 positive or suspected patients at any time during periods of respiratory instability or heightened ventilator dependence. Next slide, please. We do acknowledge in an Irish setting that resource constraints may necessitate tracheostomy formation to facilitate patient transfer from an ICU to a COVID high dependency unit or step-down facility, thereby freeing the ICU for patients deemed in a greater immediate clinical need. Next slide, please. We agree that consideration should be given for a percutaneous dilatation tracheostomy. Obviously, that will depend on what the practice is within your own institution. If the patient's anatomy and the procedure, the expertise can allow it to be done safely, and open procedures we feel may generate more aerosolization and should be avoided if possible. Choose a non-fenestrated cuffed tracheostomy tube, standard size 8 for males, size 6 for females. The cuff should remain adequately inflated to limit viral dispersion and transmission through the upper airway during ventilation. Next slide, please. When performing the tracheostomy procedure, provide adequate sedation and paralysis should be employed to eliminate the risk of coughing during the procedure. Ventilation should be paused at end expiration when the trachea is accessed and at any time the ventilation circuit is disconnected. Perform tracheostomy suctioning using a closed suction system with an attached viral filter. Using a HME or heat moisture exchanger device attached to a non-ventotracheal adapter or closed suction system instead of a tracheostomy collar during weaning to humidify the inhaled gases and minimize droplet dispersion and aerosolization during coughing and tracheal suctioning. Next slide, please. Adhere to strict donning and doffing procedures in full PPE. Limit the number of providers participating in the tracheotomy procedure and post-procedure management. Tracheostomy downsizing should be avoided and decannulation protocols commenced at the earliest opportunity after ventilator dependence and improved clinical trajectory. Next slide, please. So in conclusion, careful consideration of the location and technique to avoid unnecessary risk to healthcare providers. When clinically appropriate, delay of tracheostomy procedures by 13 days is recommended to allow for reduced viral load and decrease the risk of nosocomial infection to critical healthcare providers. Careful monitoring of endotracheal cuff pressures to maintain appropriate seal to avoid aerosolization. Appropriate PPE training and utilization, and avoid unnecessary airway manipulation such as bronchoscopy, tracheostomy changes, and a focus on closed circuit ventilation. Thank you very much.
Well, thank you very, very much for that. That was absolutely fascinating. And just to remind everybody that my colleague Pádraig Kelly put on the chat function, and to remind you it's on the web as well, that the guidelines that Paul and his colleagues devised there for multidisciplinary guidelines on the elective tracheostomy insertion in COVID-19 ventilated patients is available on the website, and the link is there on the chat for anybody who wants to open that and have a read through it. Again, a very, very useful document in these times. So moving on, next then we're going to talk about acute respiratory distress syndrome management, and Professor Ger Curley, who's the Professor of Anaesthetics and Critical Care in Beaumont and RCSI, is going to talk to us about the best way to manage those patients. And so I'll hand over to Ger now, and if everyone could just keep their microphones muted, it improves the broadcast. Thanks very much.
Thanks very much, Kieran. So I'd just like to start off by thanking the President, Mr. Mealy, yourself, Kieran in Surgical Affairs, and Paul and his department in ENT. As Paul mentioned, what's unusual about the guidelines, and it shouldn't be unusual, but it is unusual, is that these are multidisciplinary guidelines, and so often we all look after our own area, and we don't take into account what others are doing or others' perspectives. So this is a fantastic interdisciplinary effort. So I'm going to talk about the management of acute respiratory distress syndrome, and in particular in relation to COVID-19. And I have to, I suppose, preface it by saying, despite the multitude of papers that we've seen on COVID-19, and there's still a great deal that we don't know. And so next slide, please. So acute respiratory distress syndrome is essentially lung leak. If you look at what influenza does to the lung, if you look at what adenoviruses do to the lung, or if you look at what bacteria like strep pneumonia, once they get down and deep into the lung, they cause lung leaks. So normally we have a very tight epithelial layer and a very tight endothelial layer comprising the alveolar epithelial barrier. And in ARDS, this is just disrupted. And you get this protein-rich inflammatory fluid in the alveolus, and that leads to a shunt, essentially. So a lack of ventilation and shunt. And ARDS is a neutrophil-mediated disease largely. So if you do a bronchoalveolar lavage on these patients, you'll have 90% neutrophils. And if you're neutropenic, you can still get ARDS, but it's a very attenuated version of ARDS. And you restore a patient's neutrophils, and that ARDS can come back in the form of immune reconstitution syndrome. So the neutrophil is central to how ARDS happens. And there's lots of other pathways that are activated, and coagulation plays a role in ARDS, predominantly because you get this protein-rich inflammatory fluid in the alveolus, and we've all heard about hyaline membranes on pathological specimens, which are probably an artifact, but you do get coagulation in the alveolus in ARDS. But what we're seeing with these patients is they've elevated D-dimers, they've elevated lactate dehydrogenase. They seem to have a particular involvement of the endothelium and the coagulation system, and we're not exactly clear what that is. It may be microvascular thrombosis. It may also be macrovascular thrombosis and pulmonary emboli. So that's the pathophysiology of ARDS. It is lung leak, it is neutrophils, and it is clotting, and it's manifest clinically as a hypoxia and loss of compliance when you ventilate these patients, and bilateral opacities on chest radiograph. And it looks like a homogeneous disease on a chest x-ray, but when you do a CT, it's not homogeneous at all. It's more dependent regions of the lung that are consolidated. And in particular in coronavirus, what we're seeing are dependent regions, and peripheral regions seem to be more affected. There's some talk at the start that there's a classic CT picture for coronavirus, but of course, ARDS caused by a lot of different mechanisms, including sepsis, abdominal or pulmonary sepsis, and it gives you the same picture. So there isn't a classic coronavirus induced radiologic picture. So next slide, please. And once more. So this is the Berlin criteria for ARDS. It has to occur acutely within a week of a known insult. Bilateral opacities on chest x-ray, so not pleural effusions, not a nodule. The edema that you get on the chest x-ray shouldn't be because you have cardiac failure, and it's because of that lung leak that we talked about. And the oxygenation criteria for ARDS, it's mild, moderate, or severe, and that helps us to guide the therapy. So the most hypoxic patients get a particular, especially in regard to mechanical ventilation, a particular suite of interventions. Next slide, please. So ARDS of course, isn't new. It affects 3 million patients annually. If you look at any one time around the world in the ICU, 10% of all the ventilated patients have ARDS. 24% of all the patients who are ventilated, and 10% of everybody in the intensive care unit. So it's common. It's kind of a more silent disease, principally because the patients don't advocate for themselves, because they're usually sedated and they either recover or they die. And mortality is very high from ARDS. It's higher than combined HIV and breast cancer. So the more severe subset, it's up at 46%. So the mortality figures that Paul quoted in the earlier talk are consistent with this. What we're seeing from the best figures, the WHO China figures that we're seeing for mortality are just under 50%. What we're seeing in the US is a little bit higher than that. But of course, it depends on the stage of the pandemic. It depends on your ICU availability. It depends on the patients that you choose to put in your ICU. So a lot of dependent factors. But when you take large populations, that's what the mortality is. And survivors, we know from Margaret Heritage's Toronto studies, they have substantial persistent physical, neurocognitive and neuropsychiatric morbidity that doesn't go away even after a year. So even if you survive, there's significant sequelae. Next slide, please. So the suite of interventions that we have for ARDS are mainly about how we ventilate them. So you'll be aware now that we don't have a therapy, we don't have a drug that we can use to treat patients with ARDS, and we don't have a drug, despite lots of trials that we can use to treat coronavirus-induced ARDS. So most of the interventions are around how we support these patients while the lung recovers. So low tidal volume ventilation, positive end expiratory pressure, a place for non-invasive ventilation in some patients, prone positioning, neuromuscular blockade, and ECMO or extracorporeal CO2 removal. Next slide, please. So you'll see that the majority of the patients who come to the ICU are severely hypoxic, and we ventilate them with very low tidal volumes. We use high positive end expiratory pressure in most patients. We measure something called the driving pressure, which is the difference between the plateau pressure and PEEP, and it indicates really the compliance of the lung. And you want to keep your plateau pressures and your lung compliance at an optimal level. You don't want to be overstretching the lung. And most of these patients for a period will have neuromuscular blockade, and prone positioning is a prominent feature of our treatment for these patients, mostly because there's good mortality data for it, and it also really markedly improves their oxygenation. Next slide, please. So what is the place of non-invasive ventilation? And I suppose Emmett is very qualified to talk about this. But our impression of NIV is that it's useful for some patients, but that in the patients with more severe ARDS, if we use non-invasive ventilation and they fail, they do a lot worse than if you just take them and intubate them and mechanically ventilate them. So this is from the Lung Safe study, which was a global study of over 5,000 patients with ARDS that we participated in. And what the diagram is indicating is that the patients who were propensity matched who got non-invasive ventilation to patients who didn't get non-invasive ventilation, that the patients with NIV, their survival was worse. There is a place for NIV, but we use it early. Patients need to be improving on it, and patients with severe hypoxia generally should be intubated and undergo mechanical ventilation. Next slide, please. Intubation, this is our protocol for intubation in Beaumont Hospital, and I'm not going to go through it because there's a lot in it, but suffice it to say that what we're trying to do is to minimize aerosol generation and use PPE appropriately, minimize aerosol generation, and safely put in an endotracheal tube by the most experienced operator that is available. Next slide, please. So I put this slide up in all my talks for ARDS because what it does is it indicates the role that the ventilator plays. So this is from Webb and Tierney in San Francisco in 1974, and they took rat lungs and they ventilated them. And when you ventilate a rat lung with 45 centimeters of water pressure, you get what we call hepatization of the lung. It looks like a a liver. It's got lots of pulmonary edema, and it's got lots of blood, and so it gets really damaged. If you use positive end expiratory pressure, you can mitigate that lung injury. And so the ventilator, and we've known this for 35 years, the ventilator can longer, and 45 years. The ventilator can injure lungs. And how we ventilate patients is really, really important in terms of trying to improve survival from COVID ARDS. Next slide, please. And so what we try to do is to avoid overstretching the lung. So this is a pressure volume loop. So there's a region in the pressure volume loop where we'll be overstretching the lung. We'll be applying too high tidal volumes. We'll be ripping up the alveolus. And at the same time, we don't want to allow repeated collapse of the lung tissue. And so repeated collapse can also damage pneumocytes. So we try to ventilate patients in a safe zone. We try to use adequate positive end expiratory pressure and not overstretch the lung. Next slide, please. So this is the most seminal study in intensive care literature. It was the ARDS network low tidal volume study. So they took patients and they ventilated them with 12 mils per kilo ideal body weight versus 6 mils per kilo. And they limited the plateau pressures to less than 30 in the low stretch arm. And what they showed was that they could reduce the mortality from about 40% to 31%. And this ventilation strategy is a very similar ventilation strategy to what we do today. Lung protective ventilation with low tidal volumes, high PEEP, and limiting plateau pressures. Next slide, please. So there's been a slew of trials of high versus low PEEP. So essentially what we do with positive end expiratory pressure is we increase it as the FiO2 requirement is increased, which isn't very physiologic. And there are some patients who will benefit from high PEEP, and there are others who we may just be overstretching the lung. But this is a general guide. So we use these tables, these high PEEP tables, to guide our PEEP setting. And I should say that coronavirus, what we're seeing with coronavirus is a very compliant lung in the early phases of the disease. Later on, less compliant, but more compliant. So we're not really needing those very high PEEPs. Next slide, please. So neuromuscular blockade, this is the accuracy study from 2010, which demonstrated a survival benefit when we use paralysis for the first 48 hours. And next slide, we've rolled back a little bit on that. Because we have the more recent ROSE study, which was in the US, and they used a different sedation strategy and didn't really see a benefit. But we do use neuromuscular blockade in patients who are undergoing prone ventilation and whom we can't manage with sedation alone, and so who are not really syncing with the vent very well. Next slide, please. So prone ventilation is used predominantly in these patients with very hypoxic ARDS. And why do we do this? Next slide, please. So this is an electrical impedance tomography image that we've taken from a patient. So EIT is a way of imaging the lung. It's non-invasive, and it just uses a belt and some electrodes, and it gives you a picture of the ventilated lung. So in the figure A, we have a patient who's supine, and the dorsal regions of the lung aren't ventilating very well. If we turn the patient upside down, in figure B, you can see that you recruit more lungs. So you take the weight of the heart off, and the diaphragm off the lung, and it tends to open up more. And VQ matching is better when you turn patients prone as well. And you have, in general, a better plateau or pressure profile throughout the lung, a more homogeneous pressure profile throughout the lung when patients are ventilated prone. Next slide, please. So we get dramatic reductions in mortality when we use prone ventilation in patients with ARDS. So the most relevant study is from Claude Guérin. It was called the PROCEVA trial, and it's highlighted there in red. And they were able to show a reduction from a mortality of 32% to 16%. So they're able to halve mortality in the most hypoxic patients with ARDS. So that's why we're using it so frequently and why we think it's so important for patients with coronavirus ARDS. Next slide, please. So we keep these patients dry. They often come into us a little bit dehydrated, and but it is really important to try to limit the lung leak and to keep these patients even balanced or to diurese them if possible. So this is the FACT trial. Again, it's a 20-year-old trial, but it showed that you'll get patients off the ventilator and out of the ICU quicker if you use a fluid conservative strategy. So even balance or negative fluid balance every day. Next slide, please. Nitric oxide is being used a lot, and again, a lot of anecdotes of patients responding to nitric oxide. If we look at the evidence for nitric oxide, it's not great. It tends to favor the control in the meta-analysis, and in this meta-analysis from Neil Adhikari, next slide please, we see that there's an increase in the requirement for renal replacement therapy in patients who get nitric oxide through an unknown mechanism. So we're a little bit reticent to use nitric oxide. We only really use it if we're backed into a corner and a patient is dying from hypoxia. Next slide, please. So finally, extracorporeal lung support, or ECMO, has two big trials to support its use. The first was a Lancet study by Giles Peake in Newcastle. Much criticized study, showed an improved survival with the use of ECMO in severe ARDS, but the patients in the control group weren't managed particularly well outside of Newcastle. So that trial has been criticized quite a lot. And if we move on to the next slide, we see the latest Eolia study, which wasn't able to show a statistically significant benefit of ECMO for patients with ARDS, with severe ARDS, but there was a lot of crossover to the control group. So suffice it to say that ECMO has a role, and it probably has a limited role in a pandemic where we have literally hundreds of patients coming to the hospital with respiratory failure. And it's very resource intensive. It has a role, but a very limited role. Next slide, please. This is extracorporeal CO2 removal. I just put it up because we have started a patient here in Beaumont on it. It allows us to take out about 25% of the carbon dioxide that the patient produces and then to ventilate that patient in a really lung protective way. So really limit their tidal volumes and really limit their plateau pressures. And we think that it'll provide benefit again to a subset of patients. Last slide, I think. Second last slide. So specific therapies, there are some recommendations for steroids, and we stay away from it. The synthesis of the evidence for steroids in ARDS will say that patients just who get steroids improve initially, and then after 7 or 14 days, they come back to you and need reintubation, and their mortality is the same. Particular care is needed with the use of steroids for viral pneumonia. So we are steering clear of it despite all the conflicting evidence out there. Antivirals, lopinavir, ritonavir, remdesivir are being used in clinical trials, and that's the only area they should be assessed in. There is some evidence for remdesivir in a New England Journal paper at the weekend, but it's all very much observational work. I've a real concern about the use of chloroquine or hydroxychloroquine. There's a high incidence of arrhythmias in these patients, and the use of these drugs just prolongs the QT, and I'm not sure that they really will provide any benefit at all. IL-6 and IL-1 therapies are being used in clinical trials. And again, I feel there's a lot of cytokines at play. It may just be a severity of illness thing when we look at these cytokines, rather than it being the causative agent for why people decline. Convalescent plasma maybe and needs to be studied in a larger population, and other immunotherapies like immunoglobulin. So definitely last slide. Next slide, sorry. So in summary, intubate these patients when they're hypoxic, very hypoxic early, and provide lung protective mechanical ventilation. Prone ventilation and sedation, neuromuscular blockade, and conservative fluid therapy has a role. Unfortunately, these patients have a long median length of ICU stay. I concur completely with all Paul's recommendations. We should not be considering tracheostomy early in these patients, because if we treat patients too early, some of those patients will not have needed a tracheostomy at all, and some of them will die. So it is important that we stay the course with these patients until we're really sure that a tracheostomy will be required. So I'll leave it at that. Thank you very much.
Sure, thanks a million for that. And as always, it's incredibly informative. And even for a very mediocre chemist like myself, I can understand most of it. So that's a testament to your ability to communicate there. Well done. So our next speaker then is Mr. Neville Shine, who's going to talk to us about open tracheostomy insertion. And as I said, you might have heard us at the start, the last time I saw Neville, myself and himself were in Kampala, and we were part of the examinations over in Cosexa. And we were trying to put the world to rights there, I think, for a long evening. And most of that will have to be revisited in the current circumstances. I think there's a few changes to be made there. But I hope all is well with you, Neville, and looking forward to hearing what you have to say. All the best.
Thanks very much, Kieran. And thanks to Paul and Ger for being the driving force behind all of this. You can get the presentation up for me, Paula. That'd be great. So I've been asked to talk about the practicalities of performing open tracheostomy in the COVID era, primarily in those COVID ventilated patients in whom the MDT decision is for open tracheostomy. Next slide. So the primary goal of the surgery is to achieve safe, secure access to the tracheobronchial tree. So there's nothing new there. But what is a new piece is that the procedure must be performed in a way that minimizes the risk of viral transmission to healthcare workers. And that's what requires us to do old things in new ways. New slide, please. Obviously, we've already commented. Next slide, please, Paula. We've commented that these should be done from day 14 onwards. And the next slide. In reality, most will be done in theatre, preferably a negative pressure one. Next slide. But me telling people how to do an open tracheostomy is pretty much like telling these lads how to scrummage. But there has been a few rule changes in the last 8 weeks or so. So it's no longer a question of doing what you normally do. If we take that attitude, not only will we place ourselves at risk, but also those around us. So in the same way as scrum time has now become much more structured, so too has tracheostomy time. And these changes aren't huge. Some of you may consider them to be unnecessary, but the underlying driver is to create a smooth process that minimalizes aerosolization whilst achieving the primary endpoint, which is still a secure tracheal access. Next slide, please. So back to scrum time, the tracheostomy time crouch is really the preparatory phase. So this begins with the assembly of all the team members well in advance of the procedure. You run through it, disseminate any checklists that you're going to use, and nominate who's going to call those checklists. So usually one of the nurses will act as a spotter for the donning and doffing procedures. And one of the anaesthetic team is what we found works for the pause and engage intraoperative checklist, which is included in the guidelines. This is the time now to confirm the availability of all the usual equipment. You don't want to be running around looking for head rings and sandbags. And it's also the time to confirm the availability of slightly non-standard equipment, such as closed suction units, which are used in this scenario. Have your PPE at the ready, check it for its integrity. You might be wondering, the welly boots and overboots seem to have raised eyebrows, certainly in Beaumont, but the recent data from the general wards and ICUs in China do seem to suggest that the virus settles and footwear may be a significant mode of spread within the hospital environment. Then there are the little things like having a chair to facilitate the removal of your outer overboots without falling over, or a mirror for self-fit checking your respirator. I mean, these things aren't normally present in theatre. These aren't normal times, so make sure you have them there and then. Next slide, please. So the patient's now in theatre, positioned in the usual fashion, and we move from the crouch to the touch phase. And that phase extends from the surgical prep to the trachea. There's a few simple things in this sequence that ensures a smooth transition to and through the next phase. So pre-mount a viral HME filter onto the tracheostomy inner tube. Pre-mount the syringe onto the one-way valve that will allow for immediate insufflation of the tracheostomy cuff once it's in situ. And these steps just reduce fiddle-faddle later. Next slide, please. The drapes, they shouldn't be stuck or sutured or stapled to the patient. They should be nice and loose. They can be attached to themselves, but this allows them for easy removal. I would do away with the superior drape, separating the surgeon's field from the anaesthetist field. Let it be one continuous field, because this allows the endotracheal tube to be lightly secured, remain under direct vision throughout the procedure, and be immediately and easily accessible for advancement and withdrawal of the tube later in the process. So fumbling under the surgical covers, which is the normal way, just doesn't cut the mustard for these COVID cases. Next slide, please. And if you want to play there, Paula, that would be great. So for this, we're ready to now put knife to skin. There are only 2 points here that I want to point out. One is a vertical incision. Now, I use this routinely, but I do think that it facilitates an easier dissection in the plane that you're going to be dissecting the underlying soft tissue directly down onto the trachea. And the other thing is, how did I record this particular procedure? Well, with a large Hopkins rod endoscope illuminating. Now, remember, we're not going to be able to use disposable headlights. So one of the issues that has come up is, how do we illuminate deep down in a big fat neck? And I found that the Hopkins rod endoscope actually achieves this without the illumination, the rod getting in the way of the surgeon's visual field. But the real reason I want to show you this is to show you what we don't want to happen, okay? This is what we want the pause and engage phases to prevent and eliminate happening. So I'm now going to incise into the trachea here. In this patient, this is a patient undergoing a head and neck surgery. I cut into the trachea, the patient's still being ventilated, and I pop the cuff. And you'll see those beautiful bubbles there. Now, if this is a COVID case, this is a disaster. And there you go, a bit of open suction as well, just to make sure if there is any COVID hanging around, it'll be all stirred up into the ether. So it is exactly for this reason that we go through these phases. We'll come back to the stay suture, unnecessary in these patients. Paula, if you want to move on to the next slide, please. And again, onto the next slide. So we're now at the trachea, and we decide where we're going to incise. We're going to do a standard tracheostomy. And in those with unfavorable anatomy, next slide, we can consider a cricothyrotomy. Next slide. But now we're into the pause. And this is where it all happens. We go straight now into checklist mode, okay? The nominated checklist caller announces each step sequentially with verbal confirmation that each step has been completed. The patient paralysis should be confirmed and topped up. They should be pre-oxygenated. We want to protect the cuff. That's what this stage is about. So we want to protect it, and therefore we're going to advance it distally. And then to do that, we need to stop ventilating, allow for expiration, cuff deflation, clamping of the tube, and then advancement. Which is then followed by a reversal of those things: declamp, hyperinflate the cuff, recommence ventilation, and reoxygenate. So now we have done several things. We've protected the cuff. We've also demonstrated that the endotracheal tube is easily mobile within the trachea, so we don't have to undo loads of reams of sleek, and the patient's paralyzed. We can now go to the business end of the game. Next slide, please. So we're going to engage. So this is where we're going to actually perform the tracheotomy. Again, we stop ventilating. We allow expiration. We deflate the cuff. We clamp the tube. At that point, I personally make an intercartilaginous incision, and that's what I would do at this point. I would enlarge that incision to accommodate the selected tube size. And I would, with the anaesthetist, communicating directly with the anaesthetist, have the tube withdrawn in a cephalad direction to just above the tracheotomy incision, and then get them to stop. You then insert the cuff, or insert the tube, the tracheostomy tube, inflate the cuff. At that point, you put in your pre-mounted inner tube with the HME filter. Yeah, and you inflate the syringe, change the circuit over, and you wait for your trace to be confirmed, okay? If the trace is confirmed, then you move on to the secure phase. However, the first time we ran through this in Beaumont, we did not get a trace. So what you don't do is panic, okay? This is not like normal times. There's no pulling out of tubes and ramming things down. This all has to be very methodical and protocol driven. Number one, don't get the stethoscope out. If the CO2 trace says the tube isn't in the right place, the tube isn't in the right place. Do not try and second guess it. So what you want to do is undo what you've just done. So deflate the cuff. Next slide, please. Stop ventilating. Allow for expiration. Deflate the cuff. Reattach the circuit to the endotracheal tube. Remove the tracheostomy tube and then advance the endotracheal tube distally, just as you did in the pause phase. At that point, again, you inflate the cuff, hyperinflate it, re-oxygenate the patient, re-establish all your pre-mounting of what you need, get everything back in an even keel, and then once everyone's ready, go through the checklist again, the engaged checklist. Only on this occasion, you do not need to perform the tracheotomy, it's already being done, but you follow the same stepwise process once more. Next slide, please. And once that's done and you've got a confirmed trace, then you're into the secure stage. I did mention the lack of need for a stay suture or a rescue suture. I don't think it's recommended in these patients. Remember, they don't have an upper air digestive tract obstruction, okay? So if there's an accidental decannulation, the safest thing, if they do need their airway maintained and ventilatory support, is that they get re-intubated, okay? If you put a stay suture, that would almost act as a lure for someone to attempt bedside reinsertion of the tracheostomy tube with the attendant risks of false passage and what have you. And also, obviously, there's a huge aerosolization risk. So this is definitely one to be avoided. Next slide, please. So once the procedure is completed, remember that 75% of mountaineering accidents occur on the descent. And similar lessons were learned in the Ebola and SARS pandemics or epidemics. That was PPE doffing is the riskiest part of this process. So ensure meticulous adherence to protocol for doffing. Afterwards, don't forget to shower, change your scrubs, and if necessary, change your underwear. Next slide, please. So just a few final comments. Use a bigger tube rather than a smaller one. Do not rush to tube changes, as Paul indicated, the UK guidelines mentioned. Don't downsize when you're planning to decannulate, just decannulate. And decannulate sooner rather than later, because a decannulated patient is less of a healthcare worker risk. There's less risk to the patient themselves, and they spend less time in hospital. Thanks. Next slide. That's it. Good.
Neville, thanks a million for that. That was fantastic, and I think everyone's going to take an awful lot out of that, and especially I guess the whole idea of actually having to do things a little bit differently now in the context that we're at the moment, and we'll talk to you more about that at the end of the session. And that brings us on to our last speaker for this evening, which is Dr. Emmett O'Brien, who's a consultant respiratory physician in Beaumont, and he's going to talk to us about the management of these patients post-tracheostomy, especially in COVID-19 patients. So Emmett, if you're ready to go there, you can commence.
Sure. Thank you very much, Kieran, and thank you, Neville, Ger and Paul. Good evening. So I'm very happy to take part in this very interesting discussion. So a little bit about myself, my background. I'm trained in pulmonary and critical care medicine in Pittsburgh. I'm back only 6 months or so, and of course COVID has happened in the meantime. I have some experience managing post-ICU or intra-ICU tracheostomy patients, particularly in an LTAC facility, which is a long-term acute care facility where you have multi-morbid patients who have ongoing tracheostomy care needs in addition to other organ supports. What's been very fascinating, as we've seen evolve in the past few months, is how the whole team, the MDT that others alluded to earlier, have come together, and the changes in the hospital have been dramatic, somewhat refreshing as well. So what was once a normal respiratory ward is now difficult to recognize with certainly the staff fully donned in PPE and walking around you. It's hard to work out who's who, except that some of us now wear pictures of our faces to help the patients recognize their doctor and nurse. So I suppose in terms of I have only a few slides, mainly practically based. There's obviously the general issues of managing a patient with a tracheostomy, but now we have to do it in a pandemic. So within a pandemic, there's obviously other stresses on the healthcare system, particularly on a respiratory ward. You have many patients who have other acute illnesses, respiratory illnesses requiring NIV and high flow, etc. So the nursing burden is quite a bit more significant than it would be on a usual pre-COVID day. So we have to account for the patient receiving a patient who is coming into a high dependency area within a respiratory ward, but also many other patients who have other high dependency needs as well. So it's all so that we don't lose track or sight of the patient with the tracheostomy. I've also personally learned a lot about the risk to healthcare workers and managing these patients, particularly patients with tracheostomies have a number of aerosol generating procedures that are being applied on a daily basis. So not only the tracheostomy itself is an AGP, but much of the care that is associated with it. So many of these patients that come out of the ICU may still have ventilatory requirements where we're managing them with a ventilator at the bedside. That ventilator obviously can become disconnected and risks aerosolization of the viral particles. If you're weaning a patient, you may consider doing a trachea mask or indeed using some form of high flow or Airway humidification system. Again, the Airway is associated with an increased risk of aerosolization. And then, of course, suctioning. Particularly patients who are as Ger alluded to, some of the patients that are coming through have significant issues with obesity. They've also been heavily sedated and paralyzed through the course of their illness, and they are quite myopathic. So the burden on their care is significantly larger than others. So we have to make sure that when we're treating these patients that the NIV that they're receiving, the Airway that they're receiving, etc., can all be applied in a very safe manner to minimize the risk to healthcare workers. So in general, we try to do these treatments in a side room, ideally with negative pressure within the rooms. However, that's often unfeasible. With larger numbers of patients, these patients can be cohorted together and cared for in a cohorted manner. However, you need the adequate nursing ratios to maintain to do that in a safe way. And then the last thing I was going to mention on staffing and having the experienced staffing is that if our staff become sick, we don't have an infinite number of them. We know we have experience of large numbers of staff at Beaumont Hospital being off, either through contracting the virus or having close contact with it, and that can place a significant burden on others in terms of staffing ratios, etc. So it's our duty to make sure that when we apply therapies to patients with a tracheostomy, that we do it to prevent further complication to our staff and also allow the hospital to run in a safe manner. So my slide here just on tracheostomy management mentions PPE by local guidelines. So on our respiratory ward, all staff are wearing full PPE, including gloves, gown. We standardly wear an FFP2 mask on the ward with cap and the goggles along with the face shield. And all staff wear that during the daytime because the ward is an AGP zone with tracheostomy patients, NIV, etc. We have skilled medical staff, including nursing and physiotherapists who are attending to the patients. And we've adapted some of the standard ventilation circuits and non-invasive or spontaneous ventilation circuits to make them as safe as possible when suctioning the patients and also delivering ventilation. So ideally, a closed suction circuit is required. If you don't use a closed suction circuit, or if you don't apply NIV in a filtered manner, some data from the prior SARS-1 outbreak show that healthcare workers' infections increased 3 to 6-fold, which is considerable. So we really have to do this meticulously if we can. As I mentioned, patients should be ideally nursed in a side room or in a cohorted area. and then humidification, which raises the prospect of increased droplet generation. It may be necessary for the patients who are prone to mucus plugging. So we've two devices. Obviously, we have the simple HME device, which Paul mentioned earlier, or we can apply an active warm device, which heats the air. It allows it to carry more moisture, and then reduces the risk of mucus plugging and secretion desecration. We can use a trachea mask in weaning. There is some risk of droplet spread. If it's well positioned over the trach, then it may minimize that. However, our preference is to try and rapidly wean these patients and decannulate them as soon as possible. Can I have the next slide, please? Next slide, please. Yeah. Thank you. So one of the challenges in a ward environment is the absence of a fully functioning ventilator. So most patients will be receiving NIV or some form of supportive ventilation through a single limb ventilation circuit. I've created a small diagram here, which basically shows the ventilation tubing connected to an exhalation port. That exhalation port is absolutely required to prevent buildup of CO2. As this is a closed system, there's no exhale valve for CO2 to be released. So if we don't include this purple area on the in the device circuit, there is a risk of CO2 buildup. Within this, then we also have a simple HME filter. If you apply this HME filter along with the humidified, warm humidified air circuit, that can create a lot of excess water vapor, and the filter can become clogged. So it's usually one or the other, and I find it very difficult not to have the filter built into the system, because if you don't filter the exhaled air, then viral particles can be disseminated around the room. For patient comfort, then we have a flexible elbow that connects to the closed suctioning system that you'd be familiar with. And then the next slide, please. Next slide. Hello. Oh, next slide, please. Oh, thank you. And then finally, the spontaneous ventilation circuit. Again, if we don't apply a simple trachea mask, then we have a tracheostomy connection attached to a viral filter with a thermal vent, also known as a Swedish nose, which forms some form of passive humidification and can deliver oxygen to the patient. So in summary, just in the management of the post-ICU patient requiring respiratory care via tracheostomy, we just have to highlight that we do this in a safe environment with all the staff wearing appropriate PPE. We ourselves have segregated the hospital into hot zones and cold zones, and clearly the COVID positive patients remain in the hot zone. For how long, we don't know, as patients, when you serially measure them, remain positive on viral swabs for quite some time, and that can extend out up to a month or beyond based on current data. We have to manage the patient safely and minimize the risk to healthcare workers and to other patients. And then with the devices we've devised on the ward, we're trying to mitigate the risk of open suction and delivery of ventilation through these closed suction systems, along with bacterial and viral filtration to minimize aerosolization risk to the broader population. So with that, it's short and sweet. Thank you.
Emmett, thanks a million for that as well. That's a super way of concluding, I guess, the overall session, which has been incredibly comprehensive for everybody. So just to move on then, I guess, to the sort of questions that have come in. Some of the questions were submitted prior to the session, so I'm going to probably go to one of those first. I might put this to Paul, if you're there, Paul. The question we have here is, what's the survival of the intubated COVID-19 patient, and does the tracheostomy increase that survival? Does anybody wants to comment on that, perhaps?
Yeah, the question is, what's the survival of the patient, and does the tracheostomy increase the survival of the patient? So this is Ger Curley here. I'm in with Paul. So we said we'd tackle questions together. So there's no good evidence to demonstrate that tracheostomy improves survival. However, first of all, most of the evidence that we have is observational in nature, so it is very difficult to get at survival. What do we know about the benefit of tracheostomy? Well, we know that it reduces sedative requirements, and we know that a tracheostomy makes it more comfortable for a patient to be in the intensive care unit. And we're pretty confident that tracheostomy reduces the amount of time spent on a ventilator. Now, if you have had a sufficiently powered study and a well enough designed study to try to capture that, you might be able to demonstrate a benefit on mortality. But we're never going to get that. We're never going to get. We have to go on the surrogates that we have, and we know that sedation is a bad thing in the ICU. We know that sedating our patients heavily results in more ventilator-associated pneumonias, and it results in more critical illness, polyneuropathy, and longer time spent on a ventilator. So we have to use these surrogates because unfortunately we'll never get that trial, but I can't answer you that definitively.
Thanks, Ger. That's been great. I'll put the next question to Neville. Actually, people have been asking about, should I only perform emergency operations? What about just elective procedures, or how might they go about it? I think you gave a very good example of how you had to rethink the procedure there for the open tracheostomy. Is there more, in general terms, how should people maybe approach their cases to look at this?
Okay, well, with specific reference, Kieran, to tracheostomy, I mean, we would not, I think in the COVID era, the undertaking or embarking on a slash and grab tracheostomy, that's not what we were talking about tonight. So don't get me wrong that we would follow this process under those circumstances. I think, in fact, we'd be trying everything to avoid such a scenario, because you simply, in that scenario, wouldn't be able to have all the healthcare staff protected. And you may or may not be, salvaging a case that, is a salvageable case. So that's a really difficult one to answer. What we've been saying about all of these is that even the ICU cases, they're all individual case-by-case basis, okay? And it's all made, so we're all on the same team sheet. So Ger, Paul, myself, all of us discuss any of these ones that come along, and we come to a group decision. And, it means that, you go in, it's all planned, it's all nicely done, and it's the safest possible for the patient, and it's also safe as possible for the healthcare workers. So that's really the surgery hasn't changed, but it's just the risks entail within to the healthcare workers that has. In terms of elective mucosal work, well, that's completely, man, we could have 3 seminars on that one, because our specialty, the head and neck cancer, is the one that's most handicapped, because as Paul indicated, the virus lives in our world, that nasopharynx, oropharynx, trachea. So we're really hampered at the moment, even in terms of doing diagnostics. This has all been brought up with the NCCP. They're fully aware of the issues there. We're now into a zombie healthcare system at the moment. Everything is subjugated to COVID, but at some point in the next 2 or 3 weeks, things are going to have to open up, or else our COVID era related deaths are going to skyrocket, and we're going to have to start treating the patients with the ordinary diseases that would have been walking through our doors anyway. So, I mean, it's a general question. I can't give a specific answer to.
I think here,
Paul, yeah, you want to come in? Yeah.
Yeah, just I totally agree with what Neville's saying. I think the other thing to realize too is that not only is the virus live in this area in terms of head and neck cancer patients, but these kind of patients, up to 2/3 of these patients will be clinically malnourished on presentation. They'll also be smokers, arteriopaths, diabetics, cardiovascular history. So these are the typical people that unfortunately do very badly with the COVID infection. So for that reason, unfortunately, we're trying to delay matters for at least a 4 to 6 week period until we're over the worst of this, and then as well as that, to any immediate requirements, send patients down a non-operative route, i.e. radiation. So there's been a lot of multidisciplinary work to try and deal with these patients. But eventually, do we need to get back operating? Absolutely. And that is, I think, beyond this webinar, I think that is the next topic that is of huge concern to all head and neck surgeons.
I think that's fair to say, and maybe at the close of this, that the President might just say something on that, because it is an area that the college is working hard on with colleagues to see how we get services back up and running again. Just a general question, maybe to Emmett, actually. Emmett, I think Ger mentioned in his talk about the ventilators can actually cause injury, and is there a chance that maybe during COVID-19 people are ventilating too much or going there too early? What do you think?
That's a very good question. It's very topical. I think, data from the Chinese data, everybody was hospitalized with this virus as it was emerging, but quickly as the numbers grew in Italy and in England, it was realized that not everybody can be admitted to hospital, not everybody can be immediately intubated or offered a ventilator, and a large group of people started being managed with non-invasive ventilation. I tend to agree. We are learning a lot more about this disease. So Ger spoke at length on ARDS, and certainly there's elements of this disease, particularly in the later phases, which behave like ARDS, but the compliance of the lung appears to be somewhat different in the earlier phases. And conceptually it's more of a viral pneumonia, but we still don't understand the full biological impact of that. So what we have seen and what we're applying is early non-invasive ventilation for patients who have escalating oxygen requirements. We've managed to have several that get through the early process of their disease without necessitating intubation and mechanical ventilation. So there is a role for it. Overall, you have to be very cautious if you apply it too judiciously. You may inadvertently bring in people who otherwise would have benefited from earlier mechanical ventilation and cause them harm. So we're very conscious that we want to select the right patients, give them a trial run of non-invasive ventilation, and clearly if they're not doing better in the earlier phases, and Gerald and myself have worked very closely on these lines, within the first hour or two, it's usually apparent that the patients need to go to the intensive care unit and we get them down there. But there are others that do quite well and get by, and you can avert mechanical ventilation in a significant portion of patients with this viral pneumonia, which is slightly different to the ARDS group, which have other causes that bring them down the path of ventilatory failure.
Great, thanks, Emmett. I have a question in from Simon Cross here, who asked that there's just to get a call up here, there's the theory that COVID-19 attacks the heme molecule displacing oxygen hold any credence, and if so, does it offer any opportunities to provide complementary therapies to ventilator therapy? Ger, maybe you'd take that.
Thanks for that, Simon. It's an interesting theory, but it's just a theory. So it has grown from a paper in Chem Reviews that did an in silico, so essentially a theoretical analysis of the virus and its interaction with the hemoglobin molecule. So currently there's no evidence that the virus gets into the red blood cell at all. And the virus gets into cells via the ACE receptor, and the ACE receptor is present in the nasopharynx. It's present on type 2 alveolar epithelial cells. It's present on the endothelium. It's present in the heart, on myocardium, and that it's also present in the gut, and that then underlies the presentation and the clinical manifestations that we see. Patients present with a cough. They present with shortness of breath. Some of them go on to have viral pneumonia and ARDS, some of them go on to develop shock. Some of them have these microthrombotic complications. Some of them have a myocarditis. But we've had no evidence that the red blood cell or the hemoglobin molecule is actually affected. And I think that it's a theory that could be pursued in a proper biologic study rather than an in silico study as was performed. It's funny how the theory has gained a lot of traction on different media, but it's currently just a theory.
Okay. Thanks, Jared. I have another question here, and I'm not sure, maybe Paul or Paul, you might take this. Is what's the opinion re surgeons having to undergo a mask fit testing prior to tracheostomy, plus or minus the use of PAPR?
Well, the only thing about PAPR is if you've never used it before, well, that's not much good to you. You know, having a piece of kit that arrives that you have no idea how to use, that nobody knows how to decontaminate. My concern is that it's great in theory, but in the process of doffing, you might infect everyone. So if we had it, and I think does that mean that we shouldn't get it? No, I think we should look for the best, and potentially it is the best, and have it where it does come part of our routine procedures, because unfortunately COVID is going nowhere. You know, the checklist that Neville put there, when Neville was saying, well, some people might disagree or think it's a bit long, I think that's absolutely the kind of checklist that we need to be doing. We need to be really careful, because we cannot be complacent about this. And, you know, when I've heard people saying about, well, you know, wouldn't it be better just to get the infection and get it over with? No, it wouldn't, because unfortunately, there's a bit of variation and variety about how this affects people from one to the next. So, and the implications for you working in a healthcare surrounding and infecting others, et cetera, et cetera. So I think that, you know, using the PPE equipment that Neville was discussing, I think the best that we have, I think that's absolutely appropriate, and potentially with the other resources, but just we need to be careful if you get new kit into a hospital that you know how to use it. Neville might want to add to that.
Well, yeah, I mean, for a start, as far as I understand it, there is the Debbie McNamara, the National Programme Surgery, maybe Ken could confirm, are trialling the use of the PAPRs, or blowers as they're called. Certainly they've come on and advanced. None of us have used any of this kit before, respirators, PAPRs, any of us, so it's all new. And the big risk is, of course, doffing, regardless of what you use. I think, you know, people have become slightly mistrusting of guidelines and recommendations, because there was certainly a period that the guidelines were adjusted to fit whatever was in the store cabinet. And, you know, I think people need to be aware, educate themselves on what they're comfortable with using. And it's all well and good. I mean, there's a worldwide shortage of FFP2s, FFP3s, and PAPRs, and of those, the most depleted will be the PAPRs, because they are the most expensive. And it's not that, you know, you can get a box of, you know, 20 FFP3s, you know, quite handy in comparison to getting a PAPR machine. And again, a lot of it uses disposable kit. I think it's probably what we should be striving for, particularly in head and neck surgery, because again, we're going to be doing these complex, long mucosal cases, and using an FFP3, even doing a tracheostomy, you know, you're kitted out for about an hour, because everything runs so slow in comparison to previous. And that's where a PAPR machine actually comes into its own comfort, ease of use. And again, I think it's just because we haven't done it before and it's new to us. Well, lots of us are doing lots of things that are unfamiliar territory, and it just needs must. And the reality is, PAPR machines are used widespread in industry by lots of people, you know, painters, you know, people working in labs. So my attitude was, well, if they can manage it, I'm fairly sure I could get the hang of it. Handy enough.
if I might come in as well, just to echo
Yes,
what Paul and Neville said. I actually have used PAPR's devices in America. That was my usual form of aerosolization protection, as I had a beard. So since I've come back, I've had to shave my beard, and that's to make sure that the mask fits correctly. So it's one of the sacrifices that we've made in terms of looking after ourselves and our patients.
Great. Now I have a comment here from a colleague in Cavan Hospital, and it's probably something maybe for later as opposed to a question, but I guess it's been sent in, so it's just worth mentioning that they have two patients quite with obesity requiring a tracheostomy and to wean from ventilation because they're 4 to 5 weeks being ventilated. They were just wondering what sort of support maybe they should be looking for to help them with that. If anybody wants to make a comment, or is that something they just want to talk to their colleagues maybe later on about?
Yeah, it's kind of
Yeah.
Yeah, I mean, I think absolutely. I think probably it's better to talk on a maybe a one-to-one level in terms of the intricacies of those patients.
Agreed. Okay, that's great. It was worth making the comment, and again, thanks for the colleague who put the comment in there. So look, it's now heading toward, it's gone 7:30, and I guess an hour and a half is a long time for all of us to be on such a call, but the time really flew, and I really thank all the contributors, Paul, Ger, Emmett and Neville, for their incredible presentations. The video will be recorded, it'll be put up tomorrow on the website along with the information that was presented tonight. That's be fully usable there for anybody to use as education material and go down that road. Just before we close though, I just wonder if the President wanted to say anything, given the conversations that are starting to arise now about how we get surgical service back on track, and how hopefully over the next week or two, the college will be able to have more information for people on that. Ken, if you're there, if you want to say just something short.
Kieran, thanks. And I would also like to reiterate my thanks to all the speakers tonight. It really is fantastic to see these multidisciplinary teams coming together, sharing the information. It strikes me this is a fantastic forum for sharing this educational material. And I wonder, like a lot of people, that when this COVID pandemic is finished, will we look upon these new technologies as a more effective way of communicating to our fellows and members. So look, thanks again, everyone. It's really great to see the effort you're putting into contributing to these webinars, and I look forward to ongoing engagement with all our fellows and members. And thanks again to you also, Kieran, and Surgical Affairs, the department behind you, who are providing the technology which we can all use. Hopefully you'll all keep well. Thanks again.
Great. Thanks, President. Guys, thanks again for all the presentations. Everybody stay as well as you can, and I hope to get out in the sunshine and get a bit of fresh air later on if you can. Thanks to all the participants for dialing in. Next week, I think we're going to concentrate more on some of the guidelines from the Cancer Control Programme, and that may be of interest to everybody. And indeed, any more questions in any specialty, do come and talk to us in the college. We're fully operational on those things, and we can put more of these education materials together. So looking forward to next week. And again, thanks to everybody for tonight, and good night and thank you.